Thank you very much. It gives me great pleasure really to stand in front of you all in this inaugural meeting for the first cardiac surgery meeting in the region, a pure cardiac surgery meeting. So it really gives me a great pleasure. I really extend thanks to Dr. Mohammed Zubayd, who is the president of the Gulf Heart Association, and many thanks to Dr. Abdul Wahid Al-Mulla, the president of the Gulf Cardiac Surgery Society, Dr. Uthman Al-Uthman, the scientific chair, and all the board members and everybody that participated in putting together this very interesting program. And it also gives me great pleasure to present this topic on behalf of a friend and a colleague, and in this space, he is really a mentor to me in the space of cardiac leadership in cardiac centers, improving efficiency, improving productivity, quality. I learned from Dr. Khalid Iskander immensely through the past few years. I worked with him on a project, a very important project in Al Babtain Cardiac Center when he was the CEO there, where we really developed these concepts, and he spearheaded the development of these concepts. So as an introduction, what are the strategic objectives of the talk? All these slides were prepared by Dr. Khalid Iskander. I'm just here presenting it on his behalf, and I hope that I can deliver the message the way he would have delivered it. So the strategic objectives, first of all, transitioning our healthcare system to more value-based healthcare with all its aspects, including the value-based purchasing, promote accountable care organizations. And in Saudi Arabia, we are in a transformation where we are transforming into a value-based healthcare, and we are transforming into the Ministry of Health now is broken down into 20 clusters. So the main part of it is splitting the function of the Ministry of Health, where it used to be the regulator, the provider, and the payer. So now we have the Ministry of Health will be purely acting as a regulator. Then we have the health holding company, which underneath that health holding company, we have 20 clusters, which are going to act as the providers of care. And then we have the CNHI with the Center for National Health Insurance acting as a payer organization. And of course, transforming the cardiac care into IPUs, integrated practice units, in every cluster where there is a service line and an IPU. And this reflects on the care that we deliver to our patients, where it is more patient-centric. The goals of this presentation: increase access to patient care, improving the quality of care, and enhancing patient and staff experience. And here we mentioned patient and staff experience, not just the patient experience, and manage cost effectively. What are the key challenges in every cardiac center? First of all, there is inconsistent quality due to lack of standardized protocols. So we see that many of the major hospitals, we have very high quality, and then the quality is variable between cardiac centers. And that one of the main reasons is standardized protocols or national standardized protocols. The second is limited IT infrastructure. And here we want to enhance the availability of cardiac PAC systems, cardiovascular information systems, systems where the information and data could be captured invisibly, automatically, effortlessly, and we could identify gaps through the data collected, transforming our healthcare system into learning health organizations. And the mainstays of a learning health organization is data collection, continuous data collection. That's not, and I don't mean here the snapshot registries that we are performing, which are very useful, but we want to transform into a continuous longitudinal registry or data collection, where data is collected, then that data is transformed into meaningful knowledge, and that meaningful knowledge is transformed again into initiatives or performance improvement initiatives, and then data are collected again. And we continue that virtuous cycle where we continuously improve. The other thing is the referral networks, and I can see there's a lot of disparities in referral networks. We have a system called Ihalati, and we just started another function at the Ministry of Health where many of the complex cases are discussed in Sahha Virtual Hospital, where these cases, because if for example, a patient is referred for a heart transplant to King Faisal Specialist Hospital, it's better to discuss it with a team of heart failure physicians and heart failure surgeons in Sahha Virtual Hospital. And the referral when the referral comes to that physician in his hospital, he's ready to go for the procedure. And Khalid Al-Ataibi is here, and now we were discussing how can we have same-day admissions for our cardiac surgery patients, and that's a very important initiative, and I think it will increase the volume that we increase the productivity of work we do, increase the experience, the patient experience, and of course cut cost, because at the end of the day, value, when you come to the definition of value, is outcome divided by cost. So the better the outcome you have with the least cost, that is value, the higher the value that you have. So having same-day admissions for our cardiac surgery patients, we're working on that, and Khalid is, mashallah, spearheading this project. Now, the main pillars of this initiative is, first of all, optimizing the patient's journey. The second is optimization of the non-clinical operations, and the third is building capabilities. So in the optimization of the patient's journey, we have many initiatives. The first is the cardio suite, and this applies to the interventional cardiology mainly now, but we are also planning to have a suite or a holding area where also cardiac surgery patients can come in the same day of their surgery, prepared, ready, fasting, all their investigations done, a checklist is all checked out, and they're ready to go to the operating theater. It will reduce waiting time, it will increase cath lab and OR utilization, it will increase bed availability because you don't have to admit that patient to a bed and work him up while he's in-house, and it will definitely save on the costs. The second is managing the backlog and waiting time to prioritize patients. And Khalid Iskandar developed a system where he has a score for prioritization. It served us extremely well after the COVID era, because when we opened up after COVID, we found that all our cardiac centers had a huge backlog and a huge waiting list. So how can we prioritize patients? So he developed the score, and I hope that it's not part of this presentation, but I hope that we can really develop an application where we can prioritize the patients. The third is the discharge lounge, and we know that sometimes, when the patient is for discharge, till his medications are ready, till he gets his the clinical pharmacist gets around to him and discusses with him the different medications, till he gets his medical report, it takes a long time. And if he's in his bed during that time, it will prevent us from admitting, especially patients that are coming up from the ICU to the ward. And if the patient does not move from the ICU, we cannot push the patient to the theater. So if we have a discharge lounge, we could take the patient to the discharge lounge until he waits for his medications, for his report, if he needs a final chest x-ray, if he needs a quick look by the echo, that could all be done at the discharge lounge. Pathway optimization, and we have examples where we have the TAVI, the heart failure, and the ACS pathways that are applied now in our clusters. The goals of these pathways is to avoid delay in patient care and to standardize patient care. The ERACS program, and I heard, I don't know if Dr. Zaki Zahir is here, but he gave us a talk a while ago about the ERACS, the Early Recovery After Cardiac Surgery program, which is He uses a non-opioid anesthesia where the patient wakes up earlier, wakes up alert and awake and in a good condition, extubation on table or extubation in the ICU, early extubation, and of course, working on optimizing the patient's condition even in the pre-op period, where when he has his operation, is the most optimized state, and the recovery is definitely better if you do that. Fast-track diagnostic OPD, it goes without saying. When a patient comes in, instead of he gets in and has an echo, and then we need a CT scan, which is booked after 1 week. We need an MRI. We need an EP consultation. We need a dental clearance. We need 1, 2, 3, 4. So all that could be optimized. Starting on time for the cath lab and the operating theater. This definitely increases the efficiency of the cardiac cath labs and operating theaters, decreases overtime and staff cost, increases volume of cases, and it saves on cost. The cost understanding and mapping to determine the actual cost of delivery of care, and I think Khalid Iskandar has an Excel sheet where he really dissected every single procedure in Al Babtain Cardiac Center, and he knows exactly how much every procedure costs. The goal is cost transparency, identify and eliminate waste, and accurate determination of resources and their cost. Optimization of the non-clinical operations, which is also equally important to the patient's pathway and patient's journey, is the portfolio optimization, product portfolio optimization. And this rebalancing activities reduces cost, stock waste, and identifies stock at risk to prioritizing its usage before expiring. We used to have a huge waste because of expiry of products that we don't need. We order, we have them in our warehouses, and it unfortunately expires. Now this rarely happens in the Ministry of Health. Stock organization and optimization, implementing methodology that result in clear, uncluttered, safe, and well-organized stock to help reduce waste and optimize productivity. Supply forecasting, and this is very important, not over ordering, not under ordering, so you don't have zero stock at one stage in your yearly cycle, and you don't have over availability of products that you don't need and might cause waste. And the other thing is material management and reporting, inventory system to track material. This is the barcoding, the radio frequency alerts, and all that. Implementation of staff rota and planning optimization, decreasing the stress and the burnout for the staff, decreasing the overtime needed, and this will definitely improve the quality of care the staff provides. Building capabilities, the Lean Academy, and there is a educational educational material for the staff we developed with the help of consultants on Lean Six Sigma methods. Change management, where we provide the tools needed for effective and impactful organizational change, and IT capabilities, where we trained the staff to use the different software for prioritization of patient scheduling, and software and applications for the TAVI, heart failure, and ACS pathways. This is just the methodology that we used for cardiac centers assessment, built on the experience that we had from Al Babtain, and now we are doing another 2 centers. Just to finalize targets and translate existing design to implementation plan, we have activities that are included, define the target levels for KPIs, define the timeline for their delivery, and finalize the scope of initial implementation sprints, and then define the target levels, KPIs, either the clinical door-to-balloon readmission rate, infection rate, mortality, and end-plan transfer to ICU, operational KPIs, average waiting time, average length of stay, utilization over time, start on time, cancellation rate, and average expiration percentage. And workforce capabilities, the percentage of the team trained on Lean Six Sigma, and the super users, or the percentage where we have super users or yellow belts and above, and service infrastructure, population catchment area, availability of other similar activities. Just going to go, yeah, and then we have bronze, silver, gold, and platinum awards for our centers, which we are going to evaluate all our existing 23 cardiac centers and the centers that want to participate, either from the private sector or other government hospitals. If you need any more additional information about this project, please feel free to contact me or Dr. Khalid Iskandar, who is easily reachable. Unfortunately, due to family circumstances, he could not be here. But thank you very much, everybody, for attending this wonderful conference, and looking forward to more and more cardiac surgical conferences. Thank you.